Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 443 of our pharmacotherapy series, which majors in prostate cancer. The next case reads, TES is a 70-year-old male who has been receiving Leuprolide every 3 months since December 2005 for a biochemical recurrence after radical prostatectomy in 2004. He was started on bicalutamide in March 2013 for a rising prostate-specific antigen of 0.47 from 0.12, which he initially responded to. However, the prostate-specific antigen subsequently rose to 2.16 in July 2013, at which point the bicalutamide was discontinued. His pertinent laboratory results are as shown in the following table. Pause the video and carefully scrutinize it before advancing to the next slide. He continued Leuprolide and clinical monitoring every 3 months. Pertinent laboratory findings above. He comes to the medical oncologist's office for a routine follow-up appointment and complains of increased fatigue as well as a new pain in his hip. Besides this new pain, he is otherwise in good health and exercises by walking 3 miles a day. He has no known drug allergies and is only taking lisinopril 10 mg daily for high blood pressure. The medical oncologist orders a CT scan of the chest, abdomen, and pelvis, which reveals a new pelvis mass. So my next question to you reads, what would be the best treatment recommendation for TES? Let's begin with taxanes. Taxanes are the only class of chemotherapy that have shown an overall survival benefit in the treatment of castration-resistant prostate cancer. These agents are microtubule inhibitors, which promote assembly of microtubules and inhibit disassembly, thereby stabilizing microtubules and arresting the cell cycle. Prior to their development, chemotherapy was generally not effective, with mitoxantrone only providing a relief of symptoms. Next we will look at docetaxel. Docetaxel in combination with prednisone is considered to be first-line therapy for symptomatic, metastatic castration-resistant prostate cancer when cytotoxic chemotherapy is indicated. Docetaxel-based regimens were found to improve overall survival in 2 randomized phase 3 studies. Docetaxel plus prednisone was compared to the previous standard of care, mitoxantrone plus prednisone, which had not conferred any survival benefit but had improved quality of life. When docetaxel-based regimens were given every 3 weeks with prednisone versus mitoxantrone plus prednisone in over 1,000 men, there was an increase in overall survival of about 2 months. In the TAX 327 trial, 18.9 versus 16.5 months, with a p-value equal to 0.009, and in the SWOG 9916 trial, 17.5 versus 15.6 months, with a p-value equal to 0.02. Quality of life was similar in both arms of each study. Tolerability was improved when docetaxel was switched to a lower dose every 2 weeks with less febrile neutropenia and other toxicities. This every 2-week regimen may be considered in patients unable to tolerate docetaxel on an every 3-week schedule. There is recent data to support the early use of docetaxel in men with advanced or metastatic, hormone-sensitive prostate cancer. The charted trial illustrated that in men with a high metastatic burden indicated by the presence of visceral disease or high bone burden of disease, early initiation of docetaxel plus prednisone for 6 cycles in addition to ADT improved survival. The median overall survival was 13.6 months longer with a combination of ADT and docetaxel over ADT alone, that is 57.6 versus 44 months, with a p-value less than 0.001. The time to progression was 20.2 months compared with 11.7 months, with a p-value less than 0.001. A subgroup analysis of men with high-volume disease had a median overall survival of 49.2 versus 32.2 months, with a p-value equal to 0.0006. This benefit was not seen as much in men with less disease volume. Adverse effects seen in the combination group included febrile neutropenia and neuropathy. The STAMPEDE trial demonstrated an average overall survival of 10 months longer, that is 77 versus 67 months, with the addition of 6 cycles of docetaxel than those who only received standard therapy in men with newly diagnosed advanced prostate cancer. In men with metastatic disease, the overall survival was an additional 22 months, that is 43 versus 65 months. These studies provide evidence of a survival advantage with the early use of docetaxel that suggest a new treatment strategy of chemotherapy in the setting. Experience with its use in this setting will confirm its role in metastatic, hormone-sensitive prostate cancer. And now we will discuss cabazitaxel. Cabazitaxel in combination with prednisone can be utilized after progression on docetaxel-based regimens. In a randomized Phase 3 study of cabazitaxel plus prednisone versus mitoxantrone plus prednisone in metastatic castration-resistant prostate cancer patients who were docetaxel refractory, there was a 2.4-month improvement in overall survival, with a p-value equal to 0.0001, but more severe adverse effects were seen. Death occurred in 4.9% of patients, versus 1.9% in the mitoxantrone-containing regimen, mostly because of sepsis and renal failure. Other adverse effects included febrile neutropenia, severe diarrhea, anemia, nausea, vomiting, and fatigue. With the increased frequency and severity of toxicities associated with cabazitaxel, the risks versus the benefits for an individual patient should be assessed prior to use. Next we will look at mitoxantrone. Prior to the introduction of docetaxel as first-line cytotoxic chemotherapy, mitoxantrone plus prednisone was considered the only chemotherapy regimen that provided benefit in metastatic castration-resistant prostate cancer. It did not improve overall survival, but it did increase quality of life, as measured by a 29% pain response rate versus 12% with prednisone alone. Because of its lack of benefit in overall and progression-free survival, it has been relegated to last-line therapy in which there are no other viable therapies for symptomatic relief of advanced metastatic castration-resistant prostate cancer. We will now focus on immunotherapy. Let's begin with Sipuleucel T. Sipuleucel T is the first cancer vaccine to be approved by the FDA. Unlike vaccines that prevent infection by allowing the immune system to recognize the virus or bacteria, a cancer vaccine treats the cancer. This cancer vaccine stimulates a patient's own immune system against the prostatic acid phosphatase, abbreviated as PAP, antigen that is expressed in most prostate cancer tissues. Collection of a white blood cell fraction containing antigen-presenting cells are taken from the patient and then exposed to prostatic acid phosphatase granulocyte macrophage colony stimulating factor, abbreviated as PAP-GM-CSF recombinant fusion protein. The activated cells are then reinfused into the patient 3 days after collection. The infusion is repeated every 2 weeks for a total of 3 treatments. The randomized, double-blind, placebo-controlled Phase 3 study was conducted in over 500 men with minimally symptomatic or asymptomatic metastatic castration-resistant prostate cancer. Median overall survival was 25.8 versus 21.7 months in the placebo group, with a p-value equal to 0.03. Treatment was well tolerated with common adverse effects of mild to moderate chills, that is 54.1%, pyrexia, that is 29.3%, and headache, that is 16%. Unlike other treatments for metastatic castration-resistant prostate cancer, Sipuleucel T does not elicit a change in prostate-specific antigen level that can be used as an objective measure of response. And now we will discuss next-generation antiandrogen therapy. An increased understanding of the role of androgens in prostate cancer has clarified the concept that the androgen pathway is still active in castration-resistant prostate cancer. This has led to the development of new agents with proven efficacy in metastatic castration-resistant prostate cancer that work to inhibit androgen receptors, or the enzymes needed for androgen synthesis. Phase 3 trials have confirmed their utility in metastatic castration-resistant prostate cancer both before and after docetaxel. Because of their tolerable toxicity profile and ease of oral administration, they can be used prior to docetaxel in patients who are ineligible to receive or unable to tolerate chemotherapy. Regarding abiraterone, abiraterone is an androgen synthesis inhibitor that irreversibly inhibits CYP17, an enzyme that is required for androgen biosynthesis and is expressed in prostatic, testicular, and adrenal tissue. It inhibits testosterone precursors, dehydroepiandrosterone and androstenedione. When given in combination with prednisone in men with metastatic castration-resistant prostate cancer who had progressed on docetaxel, a Phase 3, randomized, placebo-controlled trial found that median overall survival could be prolonged over 4 months compared to prednisone alone, that is 15.8 versus 11.2 months, with a p-value less than 0.001. There was also a statistically significant improvement in palliation of pain because of bone metastases, prostate-specific antigen response rate, and time to prostate-specific antigen progression. Abiraterone was studied prior to docetaxel therapy in another randomized Phase 3 trial. Patients with asymptomatic or minimally symptomatic metastatic castration-resistant prostate cancer had a progression-free survival that was doubled compared to prednisone alone, that is 16.5 versus 8.3 months, with a p-value less than 0.001. Progression of pain intensity was delayed from 18.4 months to 26.7 months. This is a reasonable option in a patient who cannot tolerate, wishes to delay use, or chooses not to receive docetaxel. Because of the inhibition of abiraterone on CYP17, increased mineralocorticoid production by the adrenals can occur, causing side effects such as hypertension, hyperkalemia, and fluid retention, and should be monitored. Concomitant use of prednisone can reduce the incidence and intensity of these side effects. The most common adverse effects associated with abiraterone include fatigue, that is 39%, back or joint discomfort, that is 28% to 32%, and peripheral edema, that is 28%. Diarrhea, nausea, constipation, hot flashes, and hypertension all occurred in around 22% of patients and were severe in only 4% of patients. Atrial fibrillation also occurred rarely, that is 4%, and the most common reasons for discontinuation were liver enzyme elevations or cardiac disorders. When a patient is started on abiraterone, liver function, electrolytes, potassium and phosphorus, and blood pressure should be monitored at least monthly. Next we will look at enzalutamide. Enzalutamide is an androgen receptor inhibitor that inhibits androgen receptor translocation and binding to nuclear DNA to inhibit prostate cancer cell proliferation. Initial studies were done in men with metastatic castration-resistant prostate cancer, who had received prior docetaxel therapy as the standard of care. In the AFFIRM trial, men were randomized in a 2-to-1 fashion to either enzalutamide or placebo. The study was stopped early and patients on placebo were allowed to begin treatment with enzalutamide, because of the results seen at the interim analysis. Median overall survival was 18.4 months versus 13.6 months in the placebo arm, with a p-value less than 0.001. Quality of life was improved and there was a greater than 50% decrease in prostate-specific antigen level in 54% of patients, with a p-value less than 0.001. Adverse effects in the treatment arm versus placebo included fatigue, that is 34% versus 29%, diarrhea, that is 21% versus 18%, hot flushes, that is 20% versus 10%, and headache, that is 12% versus 6%. Seizures occurred very rarely, with a p-value less than 0.001. Overall survival was also increased, that is 32.4 months versus 30.2 months, with a p-value less than 0.001. And now we will look at radium-223. In patients with castration-resistant prostate cancer and symptomatic bone metastases and no known visceral metastases, radium-223 dichloride has been shown to increase median overall survival, that is 14.9 months with radium-223 versus 11.3 months with placebo, and to reduce pain when given every 4 weeks for 6 cycles. It also delayed time to first skeletal event, that is 15.6 versus 9.8 months, with a p-value less than 0.001. It emits high-energy alpha particles that target bone metastases by binding to areas of increased bone turnover. The short-range radiation creates a localized toxic effect of double-stranded DNA breaks in these targeted areas. Adverse effects were consistently similar between the active and placebo arms, although there was a slightly higher rate of myelosuppression with radium-223. More participants in the placebo arm discontinued the study drug because of adverse events. Patient TES has castrate-resistant, metastatic prostate cancer. He is symptomatic and his prostate-specific antigen is rapidly rising since last visit. Docetaxel is the standard of care for symptomatic, metastatic prostate cancer, and this would be the most appropriate choice for patient TES without any comorbidities or conditions that would prohibit its use. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 444.